Welcome to this HCP Live Peers and Perspectives presentation titled Recommendations on Optimal Treatment for Schizophrenia. I'm Dr. Peter Salgo. I'm a professor of medicine and anesthesiology at New York Presbyterian Hospital and Columbia University College of Physicians and Surgeons in New York. Now, schizophrenia is a complex, long-term medical illness. It affects about 1% of Americans, which interferes with a person's ability to think clearly, make decisions, relate to others. Today, we're going to talk about some of the challenges of treating schizophrenia and the benefits of long-acting injectable medications in these patients. Now, today, to discuss these challenges, I am pleased to be joined by Dr. John Kane. He's the professor and chairman of psychiatry at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell in Hempstead, New York. Welcome. Let's begin. Why don't we start with the obvious question, at least obvious to me. What is schizophrenia? I mean, I think the public has a different appreciation than we do.
Yes, you're right. Many people think it means split personality, but it's actually an illness that affects, as you said, about 1% of the population. It tends to begin in late adolescence or early adulthood, and it affects the way people think, the way they perceive reality. So some people may have hallucinations, hearing a voice when there's no one speaking, delusions, which are fixed false beliefs that someone cannot be talked out of, suspiciousness, difficulty in social interactions, difficulty with some cognitive tasks, and in many cases a lack of motivation or lack of pleasure capacity.
You know, I've seen a bumper sticker. I'll bet you've seen it too. I have schizophrenia, and so do I. And I think this is all that misconception about multiple. Where did that come from?
I guess the word schizo means split, so it's
Right.
sort of, I think it derived from that to some extent, but that, you know, many people have the notion that mental illness means multiple personality, but obviously that's a very rare form of mental illness, and schizophrenia is much more common and quite different.
Have you ever seen it? Multiple personality?
I never have. I've read about it. I've read
about it. Mind you, I'm not a psychiatrist. I've never seen it. I wonder if it really exists. That being said, you know, one of the things about doing this job is I get to sit in front of an expert and ask the questions I've wanted to ask for 20 years, and I just did it. That being said, let's go on to the medical challenges that this disease presents, because multiple personalities or no, this can be a serious medical problem. What are the challenges that this disease presents to a practitioner?
So I think the first challenge is actually early identification and engagement in treatment. So most people who develop a psychotic disorder like schizophrenia don't recognize initially that there's anything wrong. Because if they're having a delusion or they're hearing voices, they think they're real.
Yeah, people have told me that. They feel that this is real.
So they don't see it as a problem. They don't see it as a medical problem.
Right.
And it's often not until it leads to some difficulty, like, you know, behaving badly in public or something like that, or getting into a fight with someone. It's often not until that occurs that the person gets into treatment. So treatment often begins when someone is brought to a hospital emergency room, and sometimes by the police. So one of the challenges is, what can we do to educate the public so that mental illnesses like schizophrenia can be recognized earlier in their course? In the United States right now, the duration of untreated psychosis, meaning the time between somebody experiencing the onset of psychotic symptoms and actually getting to treatment, is more than a year.
More than a year.
Yeah, so you think about someone, you know, in the community experiencing delusions and hallucinations and disturbances in thinking and not getting any treatment. And this, you know, we believe this actually has consequences in terms of how someone will respond to treatment once it is delivered.
But I don't mean to say you're being glib, but isn't it facile to say, gosh, if only these people saw these obvious symptoms and they got him help or her help? By the way, what's the split, male, female?
It's about equal. Okay. The illness tends to be a little bit more severe in men, as is the case with many brain diseases.
Yeah, but it's so easy to sit here, both of us, to say, gee, you know, the family, the friends, the school, the job, why didn't you do something? But my sense of this is, it's more subtle than that. The onset is not abrupt sometimes, and the symptoms are subtle until something happens. Is that fair?
I think it's fair, but I think there is an element that the public lacks mental health literacy, that people don't understand what mental illness is. They're very reluctant to intervene, even when someone is severely depressed.
Right.
And we see that it's a problem. Or when someone has severe alcoholism and we recognize that it's a problem, we're often reluctant to intervene. And I think that's in some ways a societal problem. For us as clinicians and as psychiatrists, we're trying to think of ways that we can help engage people earlier.
It reminds me of Annie Hall, where they're discussing the alcoholic brother. And they go, oh, look at this guy, you know him. And he's having these delusions in front of Woody Allen. And he's saying, I do have these delusions about I'm going to drive my car on a rainy night off the road. And they go, oh, he's just our brother, when he needs help.
Yes.
Yeah. So what comes up next is, if it's a medical disease and there's medication to treat it, both of which are true, but you require volition daily or even several times a day to treat it, isn't that a problem? I'm talking about oral therapy. If somebody has to take pills, they've got to want to do it, and they've got to do it.
That's right. And when you asked about the challenges, so we talked about early identification and engagement, and once you engage someone in treatment, then they have to be willing to accept the treatment. Initially, sometimes people are hospitalized against their will because they don't see the need for treatment. And we have laws that allow commitment, et cetera, and that can be a horrible experience. So one of the key things, in my opinion, in the long-term treatment of schizophrenia is to avoid those situations where someone is brought to an emergency room and hospitalized against their will. That's where the prevention of relapse becomes so important.
Right.
But the question that you asked about volition, yes, we are up against a challenge when people don't acknowledge that they have or recognize that they have an illness. And what we try to do is we try to work with them around the goals that they do have. So we don't necessarily want to get into an argument with someone about do you or don't you have this diagnosis, but what do you want to do? What do you want to succeed in? Do you want to get a job? Do you want to go back to school? How can we help you do that? And that's a way to help people accept treatment when it's a goal that they're interested in.
But it's always, my admiration for you is tremendous, because you're talking to, and I know that this is a horribly inexact analogy, you're talking to the software where the software is damaged. Yes. And if they don't recognize it's a problem, you may have trouble explaining to them that this goal is reachable but only with medication, and you've got to take the pill.
That's right.
And they don't want to take the pill.
But this is where the art comes in. I mean, you're absolutely right.
Well, that's my admiration, you see.
It's a challenge, but the clinician has to be patient and persistent and also passionate about what we need to do, and that can be communicated to the patient. So I personally believe that the first thing we have to discuss with the patient is what's the nature of the illness, what are the treatments that are available to you, and what do we recommend? We're going to go through a process of shared decision making. We'd like the person to agree. In some cases, as you said, there's not going to be agreement, but we hope that we can engage the person in that conversation and gradually bring them around to the fact that treatment is valuable. And then they can begin to see that with treatment they actually feel better, they're functioning better, their relationships are better, they're able to go back to school or back to work and things like that. And then the trick becomes, how do we sustain that?
What is the longest acting oral formulation antipsychotic on the market now?
So the longest acting orals, may be a half-life of 70 hours or so. So,
okay.
They generally need to be taken daily. And as you said before, that's a potential problem because if I have to make a decision every single day to take medicine, that's very different from making a decision once a month or once every other month. But we also have to acknowledge that difficulty in taking medicine is present in every chronic illness, right? And people sometimes think, well, it's the mentally ill people who have trouble taking their medication. No, as you well know, it's people with diabetes and hypertension and epilepsy and you name it.
There's the famous study, right, which gave placebos to medical students and said, we want you to simply take one a day for a year. And at the end of the year, they counted the leftover pills, which were approximately 100 on average. Yes. They missed a third of their doses.
Yeah, absolutely. And even, I was talking to a colleague who does organ transplants the other day, and I was shocked when he told me that even his patients who need to take medicine to prevent an organ rejection sometimes have difficulty adhering.
Oh, so no, we see this. I deal in a transplant unit. Yeah. We see it.
Yeah.
So
it's human nature. I think one of our challenges is to destigmatize non-adherence. That if you have trouble taking your medicine, that doesn't mean you're a bad person or a bad patient. It's just human nature.
But there's also a stigma to taking antipsychotic
Well, that
medication.
too, yes. So we have both, and we have to help people overcome the stigma of taking the medicine. We have to help them overcome the stigma of non-adherence, and we have to be able to communicate it's human nature to have trouble taking your medicine. The fact that you need to take medicine, so do people who have diabetes, so do people who have hypertension, et cetera, et cetera. So we have to engage the person in a discussion and understanding of what it means to have an illness.
Right.
No one wants to have an illness. And these are illnesses that fortunately we do have treatments for. We can't cure them, and the treatments do need to be taken on a sustained basis, otherwise the person runs the risk of getting sick again.
Right.
And that's what we want to avoid.
Now, if you don't take your diabetes medicine, you run the risk of hyperglycemia, DKA, all the known physiologic consequences. If you don't take your antipsychotic medicine, what's a relapse like?
So you run the risk of relapse, and what happens in a relapse is that you're going to have a recurrence or an exacerbation of your original symptoms. So let's say you had delusions that the mafia was after you or something like that, and you were afraid to leave your home, or you were hearing voices all the time of a voice saying that you're terrible and you're a failure and you're awful and you should kill yourself. Then those symptoms can come back again if you relapse, and that can lead to another hospitalization and then a complete disruption in social and vocational adjustment. Mm-hmm. So if someone's been doing okay, they have a relapse, they get rehospitalized, there's a chance they're going to lose a lot of the gains that they've worked so hard to achieve.
Mm-hmm. Also, I guess if you're employed and you've been gainfully employed,
yes.
I think correct me if that's not what you were alluding to, suddenly your coworkers, your boss, everybody knows, whoops, this
That's
isn't
right.
done.
That's right.
This is still there, and he's taking meds for it. It's not cured.
That's
it's
right.
simply treated, and that's a problem.
That can lead to very obviously, very difficult consequences. If you think about, we're very focused on trying to treat people as well as possible early in the course of the illness, because we
Right.
think that's where we can have the biggest impact. And you think about a young person who's experienced the onset of schizophrenia at the age of 20, maybe they're in college or university, they're hospitalized, they have to drop out of school for a while.
Right.
But they respond well to treatment, they go back to school. If they get sick again, then they have to drop out of school a second
Right.
time. Or you mentioned a job, so let's say you have a good job, your boss is understanding and he or she takes you back after you recover, after you get over some of the initial symptoms, but then it happens again. Are you going to get the job back a second? Are you going to be able to get back to
Right.
work a second
Right.
time? So you see, or even friends, some of your friends see you in a psychotic state. It can be a little, off-putting, but they stick by you. But then it happens again and again. And what I'm saying is you can see some of life's opportunities being eroded if people have multiple relapses.
It sounds to me as if part of the problem with effective antipsychotic medication is the same as part of the problem with antihypertensive medicine. The number of people who tell me, I used to have high blood pressure, but now I take medicine, so my high blood pressure's gone, is probably close to the number of people who say, I have schizophrenia, I'm taking my meds, and I'm fine. And the antihypertensives get stopped. They get 5 normal blood pressures in a row, and the patients say, whoop, I'm cured. I'll bet it's the same with the schizophrenics.
It's similar. I mean, I wish that our medicines worked as well as some of the antihypertensive drugs. We're not quite there yet. And with antihypertensive drugs, we have several different mechanisms that we can draw on. With schizophrenia, we're still very much working with the dopamine receptor antagonist, so we're a little bit more limited. But you're absolutely right. I think what happens with many people is, okay, I've been feeling well. I don't need the medicine anymore. And then the person stops the medicine and comes in to the doctor and says, gee, you always told me that if I stop my medicine, I'm going to get sick again, but actually I feel fine. And I stopped my medicine a month ago. The reality is, even if you stop your medicine completely, it doesn't mean you're going to relapse right away. Mm-hmm. It might be 6 months, it might be 9 months, it might be a year, but the data, the evidence is very clear that the risk is considerable, and the risk is considerably greater when you stop your medicine than if you continue it.
You haven't cured the disease. Exactly. It's still there. So now we come to the difference between oral and injectable formulations. In one case, the orals, it's up to the person with this problem to volitionally take these pills.
Every day.
Every day.
That's right.
Injectables, not so much.
Right.
What are the injectable formulations out there? How long do they last?
So we have a range of formulations now, anywhere from every other week, once a month, once every other month, to once every 3 months. Okay. So there's really a range of options. And I think, people are going to vary in terms of what they think is best for them. Obviously, they're going to work with the clinical team to decide what's the best approach. But the difference, as you suggested, the difference between taking pills every day, where you have to make a conscious decision to take the medicine, you have to remember to take it, you have to be organized to take it, et cetera, you have to have it in your possession, is so different than having someone give you an injection once a month or once every 2 months. It's a completely different scenario.
So adherence is better with the injectable.
Adherence is much better, and not only is the adherence better, but it puts the clinical team in a completely different position in terms of knowing whether or not you're taking your medicine, because this has been shown in many research studies that clinicians will usually overestimate the degree to which their patients are taking their medicine, because we all think we're great doctors, we have terrific therapeutic relationships.
I don't know about you, but I'm perfect.
Well, we actually did a study where we asked doctors, so what do you think the average rate of compliance is based on the literature? These were experts in the treatment of schizophrenia. What do you think the average rates of compliance are based on the literature? And they gave us a number, and then we said, well, what about amongst your patients?
Oh.
And needless to say, the latter was a much higher estimate than the former. So I think we all have this sort of narcissistic whatever that, our patients are going to be adherent because, of course, we're.
Well, we all live in Lake Wobegon. All the women are beautiful, all the men are tall, and all the children are better than average.
Absolutely, and everyone's adherent. So
and everyone's adherent.
So, I think this has been shown in so many studies. So, one of the challenges is that physicians have to realize that they are not very good at determining whether their patients are adherent, because what do? They ask the person, are you taking your medicine?
Right.
And the person may not even remember when they've missed it or when they've not missed it. And it's not that our patients are like, lying to us. They often just don't really know whether they've taken it.
The capacity among human beings for self-delusion is infinite.
Yes, absolutely.
And the other part of this is, you get to the end of the month, you have to refill that script. And maybe the pharmacy's closed. Maybe you forgot. Maybe the insurance company has changed the formulary and you need a different brand name or a generic. And it's a hassle.
That's right. So all of those things come into play. But in addition to improving the likelihood of adherence, we're also improving the likelihood that the clinical team knows what's going on. So one of the things that we experience when a patient comes to the emergency room in a psychotic state is we're going to ask ourselves, well, was he or was she taking the medicine as prescribed or not? That's very important information. So we did a study where we actually drew blood levels of the antipsychotic drug when people came to the emergency room. We compared the results of the blood level assay to the opinion of the doctors who evaluated the patient.
That's a nasty test.
Nasty test. And needless to say, there was not good agreement. So it shows, and that's a critical decision point for the clinical team to, that your actions, your recommendations are going to be very different if you know that the patient relapsed because they weren't taking medicine or because they were taking medicine.
Now, if you take a look at the injectables, is it fair to divide them into various classes, shorter acting, kind of medium acting, and then longer acting?
Well, I think, as you said, the interval varies. So, you might have a drug that is given every other week or every 4 weeks or every 8 weeks or every 3 months. And that's, so that's based on the pharmacokinetics of specific drugs. And I think the great thing is that we have some choices.
Now, let me use a non-precise term. I'm going to use the word efficacy. And I don't mean this statistically. I don't have a p-value for it. But if you have a long-acting injectable versus a shorter-acting injectable, what is the efficacy? Compare them. Is it better to give one shot for, like you said, 3 months was one of them?
So there's no difference in the overall effectiveness in terms of preventing relapse. Let's put it that way. But the one advantage of the longer interval is that if the patient misses an injection, they can go for a longer period of time until their next injection. And that's helpful because I think one of the advantages of the long-acting formulations, as I said before, is that we know whether or not the patients received it. Because if they don't receive it, we actually have some time to intervene. And we could, we can call the family or significant other, we can do a home visit, we can do whatever's necessary. When someone stops taking their oral medicine, We have no idea. We
Right.
don't know. And it's out of their system pretty quickly.
So it seems to me, based on what you've told me, the risk of relapse is lower, not because the risk of relapse is any different when the meds are all gone, but the risk of relapse is lower with the longer acting injectables because you have more time to regroup.
Right. If you look at it that way, if you're including the period of time after
Yes.
it's stopped, then yes, that would be true. But during the time that someone is actually receiving their injections as prescribed, we don't see a difference.
And the risk of relapse with the longer acting injectables compared to oral agents, again, not while on the meds, but over the whole gamut.
Yes.
My guess is, from what you've told me, that the risk of relapse is much lower
Yes.
with the longer acting drugs because they're on the drugs more reliably, more predictably.
Yes, I mean, there are different methodologies that have been used to study that, but in my opinion, the data is pretty overwhelming that the risk of relapse and rehospitalization is lower with the long-acting formulations than with the oral drugs. There are a few randomized controlled trials that don't show that, but one of the problems when you do a standard RCT is that the participation in the trial itself really changes the ecology of care. So you're now in a clinical trial, you've signed a consent form, you are being assessed frequently, you have now a relationship with the research assistant, the research coordinator who calls you on the phone and reminds you of all of these things. So when you're studying adherence, I think you have to be very careful that the study itself doesn't change.
But studies always change everything.
They do.
Study patients always do the best.
No, that's true, and they get the best care, in my opinion.
Sure.
But there are other ways of looking at it. You can do naturalistic cohort studies with large databases. You can do mirror image studies. So those are more, I think, approximate better what goes on in the real world. You can do large, simple trials. And so when we do those kinds of studies, the results are pretty compelling, favoring the long-acting injectable formulations.
We haven't even gotten into this, but is schizophrenia a disease which can be recognized by a non-psychiatrist, by a family practitioner? And if so, can a family practitioner treat it?
I think the answer on average would be no. I think the average family practitioner is not trained to make a differential diagnosis of a psychotic disorder. I think they could certainly pick up some early signs and then refer the person to a psychiatrist. But
Okay.
in my opinion, this is an illness that really does require a specialty care. Now, there may be a point in time, however, when someone is stabilized, they're on medication, they need someone to help give the injections.
Yeah, I was going there.
Yeah.
Can they pick up from you and
Yes.
then follow the patient?
I think they can. I mean, you still want, I think, a collaborative care with a psychiatrist. We also need family practitioners and internists to help us manage the type 2 diabetes that might occur or the obesity.
You mean there are comorbidities in people?
There are comorbidities.
I've never heard of a patient with more than one disease.
Absolutely.
Now, let's say, based on what you've said, somebody watching this broadcast says, well, these long-acting injectables sound interesting. I have a patient on oral medication, maybe already relapsed once because of failure to take the pills. How do you go about switching, just mechanically, from an oral dose to an injectable?
Yeah, it's really not difficult. I mean, the first thing you want to do is decide, which medication you're going to use, because we have a choice of different medicines. Again, what's the injection interval, et cetera. Then you're going to think about the dosage that the patient has, the dosage of meds the patient has been on. You'll make a decision about, what's a reasonable starting dosage. And then depending upon which medication you choose, there are different strategies for switching. So in some cases, you need oral supplementation for a period of time. In other cases, you don't. So, you're going to want to read the package insert. You're going to want to understand the characteristics and the pharmacokinetics of that particular drug, and then make a decision about dosage and injection interval.
How do you monitor this? I mean, you're talking, again, very, very smoothly about, well, I'm going to measure this. In the clinical setting, how do you go about monitoring and titrating these things?
Well, you're always going to be titrating against clinical response. I mean, you want to get someone up to a therapeutic blood level, so you're going to follow the package insert in terms of dosage recommendations. But you're also going to be monitoring the patient for side effects and for
Okay.
clinical response. In many cases, these drugs require some time to get to a steady state, so you're going to be aware of that. And you're going to continue monitoring the patient as you would on oral medicine, except The difference is you now know that the patient is definitely getting the medicine. So one of the challenges we have when someone is on oral medicine, if they're not responding well, they're still, they're having symptoms that are not under control, we're asking ourselves, well, did that medicine not work, or were they not actually taking it?
Right.
And that can be a difficult thing to figure out.
Now, I'm going to ask you a personal question. As a practitioner now, there are a lot of formulations out there. Let's talk about the injectables specifically, of long-acting injectables. What do you, as a clinician, do? How do you make the decision as to which of those drugs to use?
So it's not that dissimilar from the decision about oral medications. It's just, we have slightly fewer long-acting formulations than we do oral medicines, but we're going to talk to the patient about their past experience with medication, different medications. We're going to understand what side effects they're particularly either sensitive to or concerned about. We're going to make a judgment about the characteristics of a particular drug. We're also going to look at the injection interval. We're going to try to decide what makes most sense for that patient. And then we're going to institute a trial of the drug that we think makes the most sense.
I'll tell you, to me, again, not treating this disease specifically, if I were to decide, you're the perfect person to tell me if I'm crazy, I would pick the one with the longest half-life. I don't want them coming back every week, every month, and I'd like this to be real smooth.
Well, you're not going to start out with the longest half-life because you really can't. I mean, so the one that has a 3-month interval, you really need to treat the patient for 4 months with the once monthly. So
is that because you need to build up drug level?
You also want to make sure they tolerate the medicine. But eventually you can get there. So I think that may be your plan. My point is just you may not go there immediately. That may be the long-range plan. So, the first it's like any decision about choosing a medicine. You're going to base it on prior experience with that drug, or perhaps a relative had a similar drug or whatever. And then you're going to, unfortunately, there is an element of trial and error in the use of antipsychotic drugs. When we're starting with a new patient who's never had antipsychotic medication, we don't necessarily know what they're going to respond best to. So sometimes we have to try 1 or 2 drugs. But people are moving now more and more towards the notion that if somebody fails on a couple of different drugs, we really should consider a trial of a long-acting formulation and not just wait until people have relapsed multiple times because of non-adherence.
Well, yeah, you pointed out that the assumption of the perfect doctor is he has the perfect plan with the perfect drug, therefore the failure is the drug failure and not the patient's failure. But in reality, if I hear you correctly, a lot of the time, the failure, is it pejorative to say a patient failure? Let's say a patient's failure to comply precisely. We'll blame the ether for this. And that if you can give something which makes it easier for the patient to comply, it's better in the long run.
Yes.
Is that fair?
Yeah, I think that's very fair.
So, again, let me paraphrase something you said earlier, because I do want to put a button on this. If we're talking about relapses, and we're talking about long half-life, oral drugs where you need not only a longer half-life, but volition, or longer half-life, which is administered in a controlled clinical setting, it sounds as if you're saying to me that the risk of relapse is much lower with injectables. And if you can get to the longest acting injectables, lower still.
Yes.
That's a monosyllabic answer. I love it. But I mean, it just makes common sense.
It does, and that's kind of what's been so frustrating about the fact that these formulations are used much less frequently than they should be. I mean, I've been working in this area doing research and the long-term treatment of schizophrenia for really several decades, and it's been frustrating to think that we do have an approach that we believe will be much more effective for many patients, but it's still not widely used. And why is that?
Well, that's a good question, isn't it? I'm not being facetious. It's a really good question. There are newer antiarrhythmics. Why aren't they being used? There's better formulations of newer hypoglycemics. And the adoption of these things takes time.
Yes, I think it's one of the embarrassments of medicine, that it takes more than a decade to implement new findings into clinical practice. In the case of long-acting formulations, it's been even longer than that. And I think, I can give you some sense of what I think the obstacles are. I think we discussed it a little bit before, in the sense that many clinicians really think their patients are adherent, so they don't automatically go in this direction. Another factor is that many clinicians will assume that the patient will say no. So if I offer you injections, you're going to say no, because why would I want injections? I don't like needles.
You know, what jumps out at me from that is diabetes.
Yes.
The assumption by clinicians, even today, that if they offer injectable insulin, the patient will say, no, my great Aunt Matilda had insulin and died. Whereas in fact, most people say, well, yeah, sure, why not?
Exactly, and so in my mind, a lot of the problem is the clinician, not the patient, in terms of this communication. And what happens is clinicians, and I think I don't want to just blame clinicians, because I think in many cases they actually haven't had adequate training in how to do this. I mean, everyone assumes, okay, we're a doctor, we went to medical school, that means we can talk to any patient about anything in a very informed and compelling way. But it's not that simple.
You can quote Pogo, right? Pogo, who said, we have met the enemy and they am us.
Absolutely. So, again, I don't want to sort of demean clinicians, because this is something I think we haven't necessarily been trained to do, and how to have these conversations. And I think, there's sort of a natural impulse to react too quickly if someone reacts negatively. So, if I say to you, I think we should use a long-acting formulation, you say, no, I don't like needles, really the challenge is, what do I say then? Do I give up, which is what many clinicians do, or do I begin to kind of have a dialogue with you over time? Right. I mean, I've had many patients who initially absolutely refused a long-acting formulation, but over a period of several months, we kept talking about it, and eventually they agreed.
You inure them to the concept.
Yeah, I mean, eventually they agreed. So or I think it's a matter of as time and patience, and giving patients a chance to express their negative feelings or their negative whatever concerns, and reassure them. So how we deliver the message is really important, and I think that's true in so many areas.
What is the actual volume of the injectate? How much do you
It varies. It could be 1 cc, it could be 2 cc's, it varies.
But when you've already told me the answer to my next question, it ain't a lot.
No, it's not a lot. It's not a lot. I mean, yes, and some people have pain when they receive an injection. Interesting, the studies show that the pain goes down over time, because as you're more relaxed, the injection is going to hurt muscle, less. Huh? Exactly. So, and I think most people who've had the experience of receiving these long-acting formulations get to a point where they prefer them. They say this really is fine. And we didn't talk about some other factors involved in taking oral medicine, in addition to remembering, but also sometimes it's embarrassing. So you're in college, you have a roommate, your roommate asks you, so hey John, what are you taking? And you might not want to say, I have schizophrenia. I mean, I hope we get to a point someday where that's fine, you just say that and nobody reacts, there's no stigma. But right now, for some people, it might be a lot easier to have an injection once a month than to take pills every day in front of other people.
I know what the roommate's thinking, and so do you. Uh-oh, he's a schizophrenic. He's going to go off. I'm in danger. I'm going to write Mom. They're going to move me out of my dorm room. I know that.
Yeah, that's very possible.
And so this is less stigma. And you say these injectables have been out for a while. Yes. I know there are guidelines for them. In fact, I got a list of them over here. So why don't we run down the guidelines and see where we are? There's an AACP guideline. What does that say?
So I think we need to start with the fact that, in my opinion, the guidelines have been very slow to catch up with the data. But the AACP guideline suggests that patients should receive oral medicine initially. They should be given a trial. If the medicine fails, then they could be given a trial of another oral medicine. But if that fails, they really should get a trial of a long-acting formulation. And if there's any evidence that non-adherence is involved, or the person is having difficulty taking their oral medicine, then a long-acting formulation should be used.
But what I heard first off is the AACP guideline is start with oral medicines.
Yes, I think most people will say start with oral medicines, because you want to be able to titrate the dose very quickly when you're starting someone on new medicine. You want to make sure that they react well to it, that they don't have any side effects. Right. And then once you do that, then you can switch to a long-acting formulation.
So it's interesting, when you're beginning treatment and you're titrating treatment, the objectives are different than once you've reached chronic therapy.
Yes.
Early on, you want short half-life, the ability to titrate, then longer, you don't want a short half-life, you want this dose to plateau.
I mean, you actually, in all honesty, you actually could treat an acutely ill patient with a long-acting formulation. We're not really there yet in terms of implementation in clinical practice, but I think someday we might be. Right now, I would be satisfied if people start on an oral medicine, give the patient a little time, understand their reaction, understand their side effects, but introduce the concept of a long-acting formulation very early very early in the discussion.
What about the NCBH guidelines? What do they say?
So they also are suggesting, the National Council on Behavioral Health are suggesting that long-acting formulations are underutilized. They emphasize that the conversation should begin early in the process, that we shouldn't wait until people have had multiple relapses due to non-adherence, and that clinicians should engage the patient in a discussion, which might include motivational interviewing. There should be shared decision-making, all of these things. But the emphasis is on doing that sooner rather than later.
Now, I was surprised that there are Florida, specific state, Florida Medicaid guidelines. And these actually include recommendations for formularies and for practitioners to implement LAIs. Where does that fit in the cosmic scheme of all of this?
Yeah, it's very similar to what we were saying, emphasizing earlier use, emphasizing not waiting until someone has had multiple relapses before considering a long-acting formulation.
Are the other states adopting the Florida guidelines?
I'm not aware, actually, of other states. I think the guidelines that people are sort of waiting for are the new American Psychiatric Association guidelines.
I was coming to that.
Yeah, so the last guidelines that the APA published were in 2004, so it's been a long time.
Can I just pause you there? Because you wondered why there was such a slow adoption rate among clinicians for anything new. Here's the APA in possession of LAI information for 15 years, right? Now they're adopting new guidelines. They're out for review.
They're out for review, but the first draft was still a little disappointing, in all honesty. So I think they've been very conservative, and the last guidelines they issued suggested that long-acting formulations should be considered in patients who've had multiple relapses due to non-adherence. In my opinion, you don't want to have multiple relapses no matter what they're due to. You want to try to avoid that from the get-go. The data suggests that more than half of our patients are going to have trouble taking medicine regularly, orally. If we know that more than half of our patients are going to have trouble taking medicine and we can't identify which patient, why wouldn't we use a long-acting formulation in everybody?
You know, I keep coming back and anchoring this as a physiologic disease and comparing it to others. There are lots of diseases in which there are newer, better formulations. And yet, the recommendations are always to ramp up from stuff we know to the newer stuff, even if we know the stuff we know doesn't work very well. It's not just psychiatry, it's not just schizophrenia, but it's wrong for that disease. It seems to me wrong for schizophrenia too.
But I also think the irony is there are many diseases in medicine where it's clearly known that people have trouble taking medicine. And if clinicians had a long-acting formulation that they could offer to patients, they would be all over it.
Do you follow any guidelines?
Well,
any published guidelines?
I think that, I'd like to think I'm a little ahead of the guidelines, if I can say that. But I think the problem is that the guidelines, it can take a while to catch up with the evidence. And I think let me add another point here. I think there's a sense that some people have that if we recommend long-acting formulations, we're somehow taking away the person's autonomy. I think
which person's autonomy, the clinicians or the patients?
The patient's autonomy. That in the U.S. we're very concerned about individual freedom and autonomy and things like that. But in my opinion, if you have a brain disease like schizophrenia or Alzheimer's disease, we also need to recognize that we're in a position to really help that person manage his or her illness in a more effective way.
Two things occur to me hearing that. First, there's nothing in a guideline which is restrictive, which says you must do this. This is simply what we recommend. And second, where's the autonomy really? If you came in with pneumococcal pneumonia, does the patient have the autonomy to take saline as opposed to penicillin? Probably not.
Right. No, you're right. And I think this is, in my opinion, this is a misperception. I think, we're not trying to control the patient. We're trying to control the patient's illness. And we're trying to work with the patient to help them control their illness. And once we've made a decision as to the diagnosis and the appropriateness of medication, then why wouldn't we deliver that medication in a way that's more guaranteed, if you will? Why not? And
right.
I think, the question people might say is, well, do the long-acting formulations have more side effects? They don't. There's absolutely no evidence that they have more side effects.
Okay.
Assuming, of course, that someone's taking the oral medicine.
So what are the rationalizations then? You're giving this to me, actually. For the early initiation of LAIs, you ramp up and go, as opposed to waiting till the cows come home.
Yeah, because I think, if we know that half of our patients are going to have trouble taking medicine. There was a very seminal study that was published out of a national registry database in Finland, where 2,500 first episode schizophrenia patients were followed. And within 60 days of discharge from the hospital, within 60 days, half of them were not taking their medicine.
Half?
Half.
In Finland?
In Finland.
Okay. Where people, I suspect, have their databases followed and people are very adherent. This is, America's the Wild West by comparison.
Well, it shows that even people in Finland are not so adherent.
Apparently not.
I think it's a worldwide problem. I think it's, as I said, it's human nature. People don't want to take medicine for many different reasons. So if we assume that half of our patients are going to have trouble taking their medicine, then why not offer the long-acting formulation to everyone? And say that this is the way we treat your illness. And I think the problem is that many clinicians will wait until 2 years, 3 years, 4 years down the road after someone's had multiple hospitalizations, and then they say, oh, well, gee, why don't we try a long-acting formulation?
Let's turn this upside down. It isn't the patient that's the problem.
Right.
It's the physician. And the assumptions inherent in most physicians that they're doing it right, and their patients are better, and their patients are adherent, all of which we know is poppycock. No?
I think so. I mean, I'm sure there are some patients out there who are very adherent, but it's hard to identify them. And I think if the long-acting formulations had more side effects or there was some reason not to use them, I could understand that. But there really is no evidence that they have more side effects. In fact, I believe that if you can use a lower dose often with the long-acting formulation because you know exactly how much medicine the patient is getting.
Got it.
And sometimes that will result in fewer side effects.
So there's no missed doses, so you don't have to give enough to counter the odd day.
That's right. And you don't have a patient who decides, okay, I'm going to skip my medicine over the weekend, and then I'm going to double the dose on Monday, and then you come in with a side effect that you're like, hey, what's going on here?
Is there a way, short of these long-awaited and often outdated guidelines, to encourage the clinicians to initiate injectables and long-acting injectables earlier?
Yeah, well, I think that's something that we're very interested in is how do you incentivize people to do this? I think this applies across all of medicine, right? How do we get those new findings implemented into clinical practice more quickly? Some of it's training. Some of it may be also access and payers. And the payers could be doing more, I think, to provide incentives. Because one of the arguments that we hear from clinicians is that, well, it's a hassle to do this. I have to find someone to give the injection. It has to be, some cases it has to be refrigerated. In some cases,
what?
Exactly.
We do this for lots of diseases.
That's right. That's right. So I think that, the hassle factor is not a good excuse.
Yeah.
But if it does take more time, maybe there needs to be some additional reimbursement for that.
What about an institutional protocol? Does your institution have one that encourages LAIs?
We encourage it. We don't have a protocol per se that says, you must do this, but we definitely encourage it, and we have lots of in-service training about the use of long-acting injectables. We have a special clinic that provides injections where we have nurses available to give injections to the patient, so it makes it very convenient, very easy.
I know we've discussed the way you approach a patient who may or may not be needle shy, for lack of a better phrase, to accept this therapy. Are there any other suggestions you as an experienced clinician can give our audience about how to start this conversation? What do you say to patients? How does it happen?
Sure. I think first, you're going to do psychoeducation, explain the nature of the illness. You're going to explain the treatment options, the risks, the benefits, et cetera. And then once you get the message across that medicine is really a very important component of the treatment for schizophrenia, then the conversation has to be, okay, I've worked with many, many patients like you, and I know how difficult it is to take medicine on a regular basis. I've had many, many patients who've been rehospitalized because they stopped their medicine or they weren't taking it regularly. I'd really like to work with you to avoid that.
Okay.
Therefore, I'm going to suggest that we start a long-acting formulation very soon. Now, right now, you were just admitted to the hospital. I'm not going to start it today. We're going to start it maybe just before you leave the hospital, or we're going to start it when you are being treated in the outpatient clinic. That way, you're setting an expectation. You're saying to the patient, this is the way we treat your illness. This is what you're going to expect down the road.
You're not dropping it on them.
That's right.
At the last minute.
Lights, where 2 years later, someone says, oh, gee, I think you should be getting this formulation. And they're like, what?
So that's what you say to patients. We know that physicians are slow to adopt anything. So let's turn it around again. What do you say to physicians who should be adopting the long-acting injectables?
Right.
How do you describe that to them?
So I think we want to have a similar conversation. Look, you have decided for your patient that medicine is recommended. That's what you want. The reason that is there have been meta-analyses showing that if you compare antipsychotic drugs to placebo in the prevention of relapse in schizophrenia, the number needed to treat is 3, which doesn't get any better than that in medicine.
No.
It is a very powerful effect. So once you've reached that conclusion, you're communicating that to the patient, then you want to work with the patient to do everything you can to ensure that they're going to get those benefits of that medicine.
Right. I have my own theory as to why it takes 10 years or more to adopt these things. I think it's generational. I think us old guys have to go away. And I think the kids have to come on and start doing the new stuff. But that's just me.
We'll see.
I don't have any proof for that.
We'll see.
I know I'm perfect, but the rest of us old guys,
It's an empirical question. We'll see.
Empirical.
So the other thing to communicate to the physicians, in addition to that message, is to better teach them how to have the conversation. And we've done role playing with doctors. So I'll play the patient, and I'll sit with the doctor, and he or she will offer me a long-acting formulation, and I'll say something, and we're going to train them. Okay, how do you respond to that? You need to be prepared to answer frequently asked questions. You need to be comfortable with that. You need to be comfortable when the patient tells you to go blankety blank because they don't want injections.
But I'm a doctor. I should simply say something, and that patient should listen to me. How 19th century.
Yes, it is.
When we
very
had
19th
almost nothing
century.
to offer. Anyway.
Yeah. And the other thing is you want to work with the rest of the clinical team. So
who is that team, by the way?
So it could, there could be social workers, psychologists, nurse practitioners, rehabilitation counselors, peer counselors. So there can be a pretty broad team in many cases. We believe in coordinated care where there are many disciplines participating. The doctor cannot do everything.
Right.
So we need to make sure that everybody in the team understands this and is on board, because if I'm a patient and I have a therapist who's a social worker, I probably have a closer relationship with that person than I do with the prescriber, right?
Right.
So if that person says, oh, I know you're adherent, you don't need to take these injections, we're done. You know what I mean? So we've got to make sure that person is also on board and understands what's going on here.
It's very close to you should never treat your family.
Well, yes, that's true.
That's the point.
Yeah.
You need to treat people as patients.
Yeah.
And it's why doctors as patients are just bad outcomes.
Yes.
What about in the hospital setting itself, hospital administrations, pharmacy administrators? How can they smooth the path here?
Sure, I think they can help in a number of ways. First, obviously, making sure these are on the formulary, making sure they understand how they need to be delivered and stored, and et cetera, et cetera. I think if the hospital can also make people available to give the injections. So a lot of psychiatrists are not going to give the injections themselves. If they have to, that may be a deterrent. So if a hospital can provide nursing to do that, if they can set up an injection clinic so that patients have easy access, That can be extremely helpful. I think that having guidelines within the hospital can be helpful, but also making sure that the clinicians, and here I'm talking about all the clinicians, not just the prescriber, that the clinicians have adequate training in what this is all about and how to communicate the message.
Most hospitals that I know have an injection clinic for something.
Right.
So why not for this?
Right, exactly.
We have some questions from our viewers. So in the little time we have left, I want to throw a few of these out at you.
Sure.
There's no warning as to what's coming, so here we go. One of our viewers asks, what does the future look like in treating schizophrenia?
Oh, well,
I told you these weren't easy.
as Yogi Berra said, it's very hard to prophesize, particularly with regard to the future. Right? I'd like to think that we are going to have a better understanding of really the nature of schizophrenia, the pathophysiology. We know that it's largely genetic, but there's tremendous heterogeneity. We don't have good biomarkers for predicting response. Much of it is trial and error, et cetera, et cetera. I would also like to think that we'll do a better job with what we've been talking about, that
Okay.
we'll take advantage of some of the opportunities that we have. I think we're also going to see better use of technology.
Okay.
For monitoring patients, for working with patients on a day-to-day basis, real time.
Here's an interesting question. What our viewer asks is the risk of developing tardive dyskinesia using medications to treat schizophrenia. How do you manage it? And in parentheses, there was a TV on today in my hospital, and there was an ad for a medication for treating tardive dyskinesia aimed at the general public. It's a real issue.
Yes, no, it is an issue, and it was more of an issue earlier in my career when we were working with the so-called first-generation antipsychotic drugs. In those drugs, the incidence was about 5% per year.
That's big.
That's big. Now with the newer drugs, it's closer to 1% per year, in my opinion.
Okay.
So the newer drugs are safer. The risk is not completely gone, but I think the risk is substantially lower. People often ask, in addition, is the risk greater with the long-acting formulations than it is with the oral formulations? And the answer to that is no. It sometimes might appear greater if the people aren't actually taking the oral formulations, right?
If you don't take the drug, you're not going to get tardive
That's right,
dyskinesia.
exactly. So, but there's no evidence that the risk is greater with the long-acting
Okay.
formulations. But it is a problem. Unfortunately, many clinicians have sort of lost track of some of the neurologic side effects because they're less common now.
Right.
There are 2 new drugs that have been approved recently to treat tardive dyskinesia. We never had drugs that were actually approved
Right.
by the FDA to treat tardive dyskinesia.
I think that's what they were advertising on TV.
Yeah, so that's good news. I mean, we do have options
Sure.
now to treat it, but we'd also like to prevent it. And the way we prevent it is by, using antipsychotic drugs only in people where it's clearly indicated.
Okay.
And trying to use the lowest possible dose.
Here's a question. We addressed this a bit earlier. Our viewer asks, what is the role of primary care physicians in managing comorbid conditions for a patient with schizophrenia?
Well, I think it's very important because I think the average psychiatrist is not going to treat type 2 diabetes or hypertension. And what we see with many patients who have schizophrenia is that these comorbid conditions are not well managed. Many of our patients smoke, many of them are overweight. The life expectancy for someone with chronic and severe mental illness in the US is 20 years shorter than the rest of the population.
Stop. 20 years.
20 years shorter, yeah.
That's a real challenge.
Yes.
For the primary care physician.
Absolutely. And as you know, many primary care physicians are a little put off by people who are chronic and severely mentally ill.
Sure.
They don't necessarily want them in their waiting room. So I think we have to work on that. We have to make sure that we as psychiatrists are facilitating access to primary care.
You make them saner, and the primary care physicians have to make them better from everything else.
For the all the medical comorbidities.
Fair enough.
Absolutely. Yeah.
All right. Here's one. I'm a payer responsible for negotiating contracts with the local system. How can I help to enable the use of LAIs?
Well, I think you want to make sure that you are encouraging their use, that you are paying for them, that you recognize that in the long run it will save money. If we can avoid days in hospital, that's associated with tremendous cost savings for the payers, for everyone. So I think they should have an incentive to really help educate people. Right now, we talked earlier about what's missing, and I said, well, there needs to be better training for clinicians on how to have these conversations. Well, I think the payers could help with that.
Again, I have a personal story about not an antipsychotic drug. But I was there when Zofran was first introduced. And as I recall, it was only in multiple vials, and they were like $1,000. You cracked it, you paid for it. I had a patient with severe nausea, and she was going to get admitted post-operatively if we couldn't fix it. That was going to cost thousands. So I opened the vial, gave her 4 milligrams, and she went home. Now, the overall cost saving was huge. What has to be overcome is the individual dose cost and the recognition that it's not in isolation, right? It's in the whole system cost, seems to me. Yeah. So here's another question. In simple terms, what elements within the guidelines should be followed to guide practice in LAI use?
Well, I think the guidelines need to be revised. I mean, that was the first thing.
15 years is too long.
It's too long. I think we need to really encourage the use of long-acting formulations and not shy away that this is somehow too controlling or too paternalistic. We're trying to control a very serious illness.
Right. Okay. We have a couple more. You ready? Sure. All right. What role does psychosocial factors such as healthy diet, exercise, vitamins, family support play in managing schizophrenia? Notice they didn't say meds.
Yeah, I think all of those things are important. I mean, we even though schizophrenia is, we believe, a brain disease and largely genetic, there are tremendous psychosocial and environmental factors that need to be addressed. People need individual therapy. They need family therapy. They need supportive education and supportive employment. They need help finding a job, keeping a job, getting back to school, all of those things. So very important. Obesity is a problem for anyone. Someone who has a chronic and severe mental illness, also a huge problem. Smoking, all the things that affect health are also going to affect the things that we're trying to improve.
One last question. Our viewer writes, how do you encourage a patient who vehemently denies that he or she has schizophrenia to seek help? And then how do you bring the injection into this?
Sure.
I think you answered the second part of that.
I think it gets back to sort of motivational interviewing. You don't want to struggle with someone about, the diagnosis or, what is this or am I ill or not? You really want to focus on, okay, what do you want to do? What do you want to achieve? What are your goals? What's missing? You can't find a job. Okay, well, what can we do to help you find a job? It may be that the erratic behavior and the suspiciousness is preventing the person from getting a job. So we're going to try to, work through the goal to achieve what we believe is the therapeutic goal.
But what sounds really tough and why you can have this job, because I can't do it, I don't think, it's some of that paranoia, some of the fear must translate even to your questions. What do you want to do? Why is he asking me? Right? How do you, there's a double, triple, quadruple risk here.
Sure, but that's the challenge of psychiatry. I think you want to establish a good therapeutic relationship with someone, earn their trust, make sure they feel comfortable, having these kinds of conversations, and that can take time. But you're also going to demonstrate that you're going to work with them to help them achieve their goals.
Except of all these diseases, schizophrenia is, at least in part, a disease of trust.
Yes. No, it's true.
Tough.
It's tough, but this is where I think many psychiatrists can feel a great deal of reward, because when they can have an impact on that situation, it's very rewarding.
It's like Billy Joel. It's always been a matter of trust. This has been a great conversation. Thank you so much for joining. I didn't know where we were going to go with this, because it's a tricky disease, and all these new therapies are interesting, and the guidelines seem out of date. And thank you so much for joining us and bringing us up to speed.
My pleasure.
All right. I want to thank you at home, too, for watching this HCP live presentation on long-acting injectable medications and schizophrenia. I hope you found this Peers and Perspectives discussion to be useful and informative. I'm Dr. Peter Salgo, and I'll see you next time.